Hello, my name is Fernando Gómez Sancha. Thank you for the invitation to participate in this Men's Health Summit organized by Ingrid Persky. She's amazing and she has managed to push this incredible program. And I'm going to participate with a talk on evolution of enucleation techniques. So let's start the journey. Of course, the evolution hasn't only been an evolution in surgical technique, but we have also witnessed a technological journey. We have seen how lasers get more sophisticated, surgical instruments get better. We have thinner endoscopes, we have faster morcellators and blades, and excellent video systems that allows us to perform the operation with much more safety and uh, easiness than I think the original surgeons who started doing enucleation had. So the beginning of enucleation, endoscopic enucleation of the prostate, was the description of Hiraoka from Japan of his en bloc enucleation of the adenoma endoscopically. He used a monopolar blade, and he didn't publish a lot of data. He operated more than 4,000 patients in Japan, but he never published the data, and he was largely ignored, let's say. He was not recognized until much later. And Peter Gilling and Fraundorfer developed the holmium laser enucleation of the prostate technique in 1989. What they did was to incise the adenoma and remove the adenoma in three pieces. This was the three-lobe original technique description by Peter Gilling and Fraundorfer. And they are considered the fathers of laser enucleation of the prostate, of course. And they also contributed with very important papers presenting very good quality evidence that this operation was jolly good, was very good. There has been so many. I reviewed many of the papers on surgical technique, and I have to say that there have been many different contributions, many different ideas that have taught us a lot about this operation. And here is the mushroom technique described by Hochreiter when morcellators were not so easily available, and so the enucleation could take place with laser, and then the lobes were kept hanging from the bladder neck and then resected with a resectoscope. So the morcellation was carried out with a resectoscope. Also, morcellation was studied and described in different ways, and there was a possibility, a description of the upside down technique, which is very common in Asia, and I have to say it's a very good and very useful technique. So it's very nice to be able to morcellate not only looking up, but also upside down, and as it is very efficient, especially when the tissue is harder. Initially, when surgeons were trying to enucleate with a thulium laser, with a continuous wave thulium laser, many times they removed three lobes, but there was still tissue left behind. And it was Thomas Hermann who described the anatomical technique for enucleation with thulium laser. There was a lot of mechanical dissection of the plane, guiding the dissection, and the operation improved towards a more anatomical operation. Also, there were some groups recognizing that instead of doing three lobes, we could do two lobes. So this two-lobe technique was proposed by Michael Dusing and the group from Dr. El Hilali in Canada. And as you see, this explosion of creativity on how to perform enucleation started. The Japanese urologist Endo also published his anterior-posterior technique, which was trying to preserve the sphincter a little bit better. So I think this was a great idea, and he still did lobe-based, incision-based technique, but when he was going to dissect the sphincter area, he started at 12 and went downwards, so that he didn't use the endoscope to carry out this apical dissection, which showed much better results in continence. We presented our experience with the green light laser. Initially, nobody thought that enucleation might be carried out with a green light laser, but the same way as a continuous thulium laser was used for enucleation, and a lot of mechanical dissection was performed with the tip of the endoscope, We presented an initial video where we did a 12 o'clock incision and then removed the rest of the adenoma en bloc. But gradually we went towards performing a proper en bloc enucleation, removing everything in one piece without incisions. At the time, I didn't know what Hiraoka had published, and when I published this paper, he contacted me and said, "Look at my paper. I did this many years ago with an electrode, with a monopolar electrode." And he had it all figured out from the beginning, but we didn't really know about this. Then Dr. Gong presented his enucleation technique, where he would do a posterior dissection all the way to the bladder neck, and then he would do an incision at 6 o'clock, and then he would dissect the adenoma into the bladder. There's also another Korean technique, the all-in-one en bloc technique, that was also recognized. So you see that there are many variations. Incredibly, many of these papers were published when the authors didn't have a lot of experience with the procedure. They usually, these initial technique papers report a very low number of patients. So sometimes I think some papers and some techniques are more based on experience than others. So also there is a desire, natural desire in all of these urologists to describe their own technique and to try to, let's say, reach the glory by publishing a singular technique. But not always these techniques have the same degree of thought and experience behind. For example, this technique presented by Cesare Scofone, the en bloc no touch technique, was trying to do an incision at 5 o'clock and then produce an ascending incision to dissect the lateral lobe. At that time, the sphincter was not touched, and he would try to put the endoscope on top of the adenoma and do the dissection of the bladder neck from 12 to 9, even without touching the sphincter. And then he would ascend from the other side to communicate, and then finally he would do the, this late release of the apex, which sometimes, and if you can look at the drawing, might cause some deepithelialization of the sphincter. Also, Minagawa presented his anteroposterior dissection. So basically he was doing a 12 o'clock incision and then enter also below and then communicate anterior with the posterior to try to remove the adenoma in one piece with a 12 o'clock incision. So very similar to what we did initially with Greenlight. Miernik presented another technique where he describes that he used 3 horseshoe incisions, trying to make it simple, trying to simplify. So he would do one to enter the posterior plane, then he would do another one when he was going to dissect the 12 o'clock area of the sphincter. Here he was describing this 12 o'clock flap again, which probably was not working very good in terms of immediate continence after enucleation. Then we described, I transitioned from Greenlight to Holmium, and I tried to reproduce the technique that I had seen that was giving us very good results, especially very good continence results. So we published this adaptation of the en bloc technique that we had described before with Greenlight laser to be performed with a Holmium laser. And this we already knew that releasing the apex early and protecting the sphincter's mucosa had a big influence in the postoperative results, especially with the incontinence rate. Also, Thomas Hermann published his update on TULEP and how to perform TULEP to his understanding, with initially dissecting one lobe and then doing the dissection of the middle lobe and the other lobe in conjunction. So as you can see, variations on the same theme. Also, Ito developed this en bloc operation with direct bladder neck incision. He means by that as soon as he enters the lateral plane, he goes to the bladder neck and incises the bladder neck and then tries to continue the dissection of the adenoma circumferentially until he can release the sphincter from the apex in one side. So it's incredible to see these techniques all together, because you realize how there are many ways to skin a cat, no? And we are starting to see that These are just, let's say, probably small variations like this omega sign incision published by Lufti Tunk from Turkey. He says that this technique is providing very good continence results, and he tries to preserve the anterior fibromuscular stroma and remove the lobes, but respect a lot of the tissue. And he published 4 years later a study, anatomical study, trying to demonstrate the importance of the muscle fibers of the sphincter penetrating the anterior fibromuscular stroma. And he says that this is the basis for his technique. But the fact that the anatomical study was performed 4 years later than the description of the technique is not giving it a lot of credit, in the sense that probably when they looked at the anatomy, they had a bias, a confirmation bias. They wanted to prove their point, and probably they interpreted the anatomy of the prostate, which, as you know, is very rich in muscle fibers. Then Felipe Figueiredo and Scofone published their evolution towards an en bloc technique, in this case with a progressive early apical release, where again they were using some ascension of the dissection, but then they would go from 12 to 6, let's say, or to 9 and 3, trying to descend in the apical dissection to try to prevent the incontinence. And many times they would do an incision at the end, trying to facilitate the removal of the adenoma and the dissection of the posterior plane. And finally, this is the last technique I review. It's impossible to include them all because there's too many. This is the another technique trying to do an en bloc, let's say, resection of the adenoma, but performing an incision at 11 and 1, trying to preserve the fibromuscular stroma. But in this case, the early incontinence was quite high and a little bit, going against the idea that this is going to preserve continence much better. So I think that the problem of incontinence after HOLEP is probably based on this infamous encircling maneuver. When the early surgeons were performing enucleation, they would use the shaft on the end of the endoscope to go towards 12 o'clock, which might remove. You can see in the video that the sphincter is deepithelialized. The mucosa of the sphincter has been ripped, and this sphincter devoid of mucosa could probably experience some difficulty to hold the urine, at least until the mucosa grew back. So I think the concept of the mucosal curtain at 12 o'clock and the infamous encircling maneuver were probably responsible for this early incontinence. And the difference between the classic HOLEP and these approaches, because I'm not only saying that en bloc is the only way to do this, the achievement of empty fossa and a preserved sphinctus mucosa might be very important to preserve continence in patients. So I think the surgical technique has to try to preserve the sphinctus mucosa, because it makes a big difference in terms of early incontinence results. We are moving lower than 3, 4, 5% in our patients, even with very large glands, and it recovers really, really fast compared to the 30-40% that was reported in previous studies. But also this urologist from Israel, Dr. Stoffer, very ingeniously was going to do a ureteroscopy in a patient who needed HOLEP, and he looked at the sphincter position and he marked with some staples, on the surgical drape, the position of the sphincter, and then he did some x-rays looking at how the sphincter position changes during surgery, during enucleation. So he postulates that the more you angle the scope, the more chances of distending the sphincter, and these radial forces exerted by the endoscope might be another important cause for early stress incontinence after enucleation. And it's very interesting that one of the things that I like from the block approach is that if you have to do a 12 o'clock incision in a patient where you're going to do a 3-lobe technique, or an incision technique where you have to cut at 12, typically you have to angle the scope very much. And you see, when I'm going to with my en bloc approach, or with the en bloc approaches, I think when you're going to enter the bladder, the endoscope is quite horizontal, and that's because the en bloc technique is able to capitalize the mobility of not only of the adenoma inside the capsule, but also of the fact that you're pushing the adenoma downwards is going to lower the prostate and the bladder inside the pelvis, and that changes of course, the possibility of damaging the sphincter. So I think one of the genuine advantages of en bloc is that when you are on top of the adenoma, you can bring everything down, not only the adenoma inside the capsule, but the whole prostate comes down, and that will probably reduce the stress on the sphincter. And also, when you work laterally on both sides, you can also push the adenoma a little bit towards the side, and there will be some mobility of the prostate that will allow to bring, let's say, the surgical field towards the center. So I think, as a conclusion, surgical principles are probably more important than the specific way or that the surgical techniques are promoting. I think that providing that technique, however it works, protects the sphincter function and ensures a complete removal of the adenoma, I think the clinical result is going to be really good. And we need to preserve the sphincter mucosa. We need to avoid doing a lot of traction. And then I think it's important to move slowly with the endoscope and not do very abrupt movements to let the sphincter adapt to the distension. So in my opinion, probably en bloc is simpler, faster, and easier to learn. And this is the end of my talk. I don't know if I'll be able to connect to answer questions if there are any. Otherwise, thank you very much for the invitation, and I hope you enjoy this amazing congress.